Welcome everybody to our virtual Compassion in Action Healthcare Conference. We are thrilled that you're joining us today. I'm Beth Lown, the Chief Medical Officer for the Compassionate Schwartz Center for Compassionate Healthcare. And we have just a terrific session today. Please join me in welcoming Dr. Mary Bassett, Director of the Francois Xavier Banu Center for Health and Human Rights at Harvard University. Dr. Bassett, we are so thrilled to have you with us here today. Thank you for being here.
Oh, and thank you, Dr. Lown, and thank you to the organizers, and congratulations on keeping the Compassion and Care in Action conference going through these pretty strange times that we're in. It's been a while since I've been asked to give such a long talk. Zoom has shortened us all, but I'm really glad to have that opportunity because it gives me a chance to talk about the time that we're in a little more detail. So let me just bring up my slides. And although the title of my slide, of my talk is Health Equity and COVID-19, and I am going to cover that, I thought since we have some time that I would take the time to go through with you what we're talking about when we talk about racism in the United States. And I'm going to be talking about the way in which these fissures in our society have appeared also as the COVID-19 pandemic has arrived on our shores. But I think that understanding sort of the larger picture is an additional key contribution that I can make, because compassion is based on truth and based on commitment. And in anyone who lives in this country and who seeks to have a compassionate engagement has to think also about what it means to talk about racism. So I'm going to start out with that, talk about the connection between racism and health, and then move on to finally end up talking with what I was asked to talk about, which is the kind of disparities that we see by race, ethnicity with COVID-19. Sorry, everybody. Open, the door is open. So I put in this photograph to really talk about the United States. And this is a picture of the Atlantic Ocean. It appeared on the front cover of a wonderful piece that was done by the New York Times in August of last year in commemoration of 1619. 1619 is the year that the first enslaved Africans were brought to the United States. They were captured Africans who arrived on a Dutch slave ship captained by an Englishman who were traded with people in Jamestown for provisions. And in many ways, people of African descent in the United States really were born on this ocean when their period of enslavement began. That's been 400 years, and the transatlantic slave trade went on for centuries. It involved, it's estimated, 12.5 million Africans. Millions died on the crossing. And many people aren't aware that really the larger portion of enslaved Africans went to South America and the Caribbean. You can see that small arrow here is the number of enslaved Africans who came to the United States. And many people think that they went immediately to the South. And of course, people did go from the Caribbean to the United States subsequently. But just to remind ourselves that, that there were enslaved people in every one of the colonies, and about 10,000 enslaved Africans were brought to Boston. So this is where it began, and with the very founding of the United States. And Shirley Chisholm, who some of us like to remember was the was the most prominent woman before Hillary Clinton to run for president of the United States, said that racism is so universal in this country, so widespread, deep-seated, that it's invisible, that these many decades of enslavement followed by the marginalization and discrimination against people of African descent have normalized the second-class citizenship of African Americans. So this is a definition that I like to use of racism, and mainly because it highlights the idea that racism isn't simply about personal prejudice. It's not about thinking that people with brown skin and African features are somehow inferior to others. It's the ability to act on those personal prejudices, having the power and the ability to control resources so that racism results in a social impact. And it's not just about feelings. So this is a definition that's now, 25 years old. That is, nope, not quite, that is useful to me. And this is a taxonomy of racism. And these days, many of you are probably hearing the phrase systemic racism or structural racism. And it's in many ways the platform upon which these different forms of racism exist. But when I was the health commissioner in New York City, we adopted this framework, and I do think it's quite useful. First of all, there's internalized racism, the effect that racism has on individuals, including people of African descent. And it was probably, for me, it remains best captured by this study that was done by Kenneth and Mamie Clark, called the doll study. This was a study in which a Black child, was asked to identify the nice doll, the pretty doll, the intelligent doll, and was shown a doll that looked white and a doll that looked Black. And the overwhelming majority of children identified the white doll as the good, smart, and pretty doll. This study was repeated by a high school student in the 1990s, and she found exactly the same thing. So this is the beliefs about oneself that a person of African descent develops. And most of the time when we talk about racism, we're talking about interpersonal racism. And that's the kind of exchange that occurs between individuals. It can refer to explicit racism, in which people use racist language, or it can be more implicit, or what some people call microaggressions. And most of the time when people think about racism, they're thinking about this. But in addition to that, there's also institutional racism. When we sit around in our institutions, if I work at an educational institution, and I sit in faculty meetings, and I notice that there are hardly any people of color in the room, this reflects institutional practices. This is a photograph from a study that was done by this is a photograph of a picture that was taken in New Orleans when the decision was made by the federal government that they had to desegregate their schools. These are federal marshals accompanying this small child, obviously in her Sunday best, who unleashed several days of rioting in New Orleans because she was being brought to a previously all-white school. So this refers to the practices of discrimination by institutions, not simply by individuals, that results in the exclusion of people of color. structural racism or systemic racism is something that is even more widespread than that. And it includes, it's a very long definition here. It appears in a paper that the health department wrote with researchers at the Harvard School of Public Health. And I'm just going to read it out to you. That structural racism involves interconnected institutions whose linkages are historically rooted and culturally reinforced. It refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect the risk of adverse health outcomes. And the pathways between racism and health are multifold. Obviously, an important way that racism operates in our society is to distribute people of African descent to lower economic strata with lower incomes, and in particular lower wealth. The racial wealth gap is enormous. Black wealth is about $1 for every $100 controlled by white families, and in the city of Boston, as we'll see, it's even larger than that. But it extends to exposure to unhealthy environments. It includes the psychological dimensions of enduring ongoing racial exclusion and the trauma associated with witnessing violence and witnessing and experiencing unfair treatment. It includes the way in which, for example, unhealthy foods and other unhealthy products like tobacco and alcohol are differentially promoted in communities of color. It reflects the lack of access to health care, both related to lack of health insurance and to lack of available services. It includes police violence and exclusion from voting rights, which, as you know, were only achieved by the Black American population in the mid-1960s. And it includes also the ways in which communities of color adapt strategies that are unhealthy, but are in response to these phenomenon. And stereotype threat, I don't know if I have time to talk about it. It can come up in question and answer. It's interesting. So in many ways, structural racism is the platform sorry, let me go back. Whoops. Let me see if I can go back. Huh. I'm not sure how to go back. This is bad. Sorry, everybody. All right, there we are. So in many ways, structural racism is the platform. And really, when we talk about racism in the United States or in any country, it can't really exist and be perpetuated without being structural. So in a way, this is almost redundant, but I think it's important to break it out just to understand the multifold ways in which racism operates. And these days, many people talk about what are called the social determinants of health, the ways in which our everyday lives are so important to our health, our housing, our employment, our education are all important to health. And racism, I see, is really antecedent to the social determinants of health, so that all of the things that we think of as social determinants of health are in this racial hierarchy that the United States has maintained and still maintains. All those social determinants are filtered through the existence of racism in the United States. So here is a map which shows Boston, and it is a map actually that was created by the Boston University School of Public Health, but many of these maps exist for many cities all over the United States. And it shows the real variation in the risk of death by what neighborhood you live in. And the observation that if you get off at Dudley Square, which when I was a student in Boston was called Dudley Station, you have a much higher rate of dying before your time than if you live in Arlington, for example. It's more than twice as high. And I'm told that there are very large gaps in life expectancy in Boston, so that the gap between Roxbury and Back Bay is more than one generation, 30 years. Now, if you think about why these neighborhoods look like this, and in New York City, we make similar maps, and I never asked myself, why do these neighborhoods look like this? And the answer to this is the phenomenon of redlining, that in Boston, we have had this legacy of redlining that still determines the social architecture and the geographic, social geography of Boston, same in New York, same in over 50 cities where these maps were drawn. And they were drawn to identify neighborhoods that were considered hazardous or declining. And you can see, well, those of you who know Boston maybe better than I do, that the very neighborhoods that were identified as in red in the 1930s are the ones where we see excess mortality today. So this is a map where the darker colors show the places in Boston that have higher mortality rates. And they line up, as they do in New York City and in all cities where redlining, that I've looked at where redlining was performed. So what was redlining? Well, for me, it's often the most useful example of what we mean by structural racism. And it dates to the 1930s when the federal government began a program to try and increase home ownership as part of the recovery from the Great Depression. And the way in which this program was organized effectively deprived African Americans of access to these low-cost mortgages. It used to be that you had to have, a huge share of the purchase price of a house in order to buy a house. But with this program, the down payment went down to 10%. It's now up to something like 20% following the 2008 crash. But this was an enormous change in the ability to purchase a home. But the neighborhoods that were where most African Americans live were literally redlined, those maps that I've just shown you. And these families families that lived in these areas who were overwhelmingly African American families lost access to this federal housing authority program. Now, we talk about it as structural racism because it was not any single institution that did it. Importantly, government backed it. It didn't matter if the banker that you went to talk with about getting a home mortgage liked you or didn't like you, had feelings about Black people or not. If they looked at those maps and you were redlined, you weren't going to get a mortgage. So it was independent of personal prejudice in that sense. And of course, it was also reinforced by these private covenants that were used by private developers. So it wasn't just one institution, not just the real estate agents, not just the bankers, not just the government, but all of these working together. And the phenomenon of redlining and the barriers to home ownership and the ways in which Black families were forced into predatory loan markets in order to purchase homes have a huge role in the wealth gap that exists in the United States to this day. As I've mentioned, the income gap is substantial, with Blacks earning between 60 and 70 cents on every dollar earned by whites, but the asset gap is even wider. And in Boston, a study that was done by the Federal Reserve Bank, which there is one of the 10 across the country is housed here in Boston, showed really a staggering wealth gap, with Blacks having on average $8 in family assets. This is household wealth versus whites. And the difference there, I think most of you can guess, is whether or not people own homes. In fact, for Blacks of US descent, the asset would be zero. It was the group that they classify as Caribbean Blacks who explained the fact that assets for people classified as whites, as Blacks, got to $8. And of course, all of this has an impact on the likelihood of dying young. Dying young in this graph refers to dying before the age of 65. Now the standard cut point for premature mortality in the United States is 75, but in this case, premature mortality is defined by 65 years. And this is a time trend from the 1960s all the way through the early 2000s that was put together by colleagues at the Chan School of Public Health. And these top solid lines are people of color. It used to be that they only classed Negro and white in the census, and now, of course, there are many more possible racial categories. So they all go into non-white versus white, and you can see, and each line is an income quintile by county of residence. So the first thing to notice, of course, is that mortality has declined for everyone, which is really good news. The other thing to notice is that for most of time, and for many whites, all whites, regardless of their income classification, had lower rates of premature mortality than people of color. This is the highest income group of people of color, and they only crossed the line with the lowest income group of people classified as whites in the early 1990s. So income has long had an important impact on mortality, as has race. But in our country, the impact of race is especially large. All right, so that was what I was going to cover with you to cover the sort of global picture of what we mean by racism and what we understand about the connections between race and income and health. And now for the remainder of my remarks, which I guess I have at least 15 minutes for, I'm going to talk about what has happened with the COVID-19 pandemic with respect to racial and ethnic disparities. It's hard to imagine that, as we are now approaching 150,000 deaths, that the first death reported in the United States was at the end of February, on February 29th, as a matter of fact. But it was very soon after that jurisdictions began reporting appear to be large racial disparities in COVID COVID-19 deaths. The first place that I am aware of was Milwaukee, which, by the way, was the city that declared racism to be a public health crisis over a year ago. So Milwaukee noted that at the time, there'd only been 15 deaths in the state of Wisconsin. 8 of them had been in the city of Milwaukee, and all 8 deaths were among people classified as Black. So they expressed concern, and this concern followed from other local jurisdictions, Chicago, New York, New Orleans. In general, they would report out the proportion of the deaths that were classified as among Blacks, and the proportion of the population that group represented. So in Milwaukee, for example, 100% of the early deaths were in African Americans, and 38% of the population was African American. But interestingly, there were at the time no national data being reported by race ethnicity. The CDC was reporting data only by age and gender. And they just began to make the data available by race nationally a few months ago. These data are national data that were released by the National Center for Health Statistics and by the CDC sometime in May, and they went through May, to May 20th to be exact. We've recently reanalyzed these data. And by the way, the Centers for Disease Control is not offering these analyses. They've had to be done independently. And I can't tell you what those data show, but I can tell you that it's the same story, that these measures haven't shifted by very much. And the main difference being that Latino mortality rates seem to be rising. Okay, so I'm going to start showing you some data, and I don't know much about my audience, so I'm going to take a minute to make sure that I state in plain language what some of these measures mean. So these are age-adjusted rate ratios, and what that means is 2 things. One is that the rate of death is adjusted for age. We all know that the risk of death goes up with age. So the underlying population structure has a bearing on how we understand the mortality rates. If you're all an older population, we would expect the mortality rates to be higher than if you were all a younger population. So these are age adjusted. And then they're a ratio because the rates for Blacks and other populations of color listed here are compared to whites. So the way you would put this in plain language is after adjusting for age, Blacks are 3.6 times more likely than whites to die of COVID-19. And all populations of color are more likely than whites to die of COVID-19, with Latinos in here. And as I said, the more recent data show this ratio to be a bit higher, but still under 3, 2.6-fold more likely, and so on. Now, it's important to have summary measures. This means across the population, there's a 3.6-fold higher risk. But we were concerned about looking at how the rates differ by age across the life course. And this graph shows that across all years, and you can see from this graph that the risk of death goes up a lot with age. but across all ages, and you can't make it out here because there are relatively few deaths, the population classified as whites has the lowest risk until these are American Indian, Alaska Native, and this is an inaccurate statistic for a variety of reasons. The denominator data that we get from the census is inaccurate for American Indians. So we wanted to look at how, when we look separately by age group, instead of providing a summary measure, but look separately by age group, what the risk ratios look like. And these are all compared to whites. So that between the ages of 25 and 34 years, because the risk, the number of deaths under the age of 25 is extremely small. So I'm not going to show you that because those are so unstable. Here we have a 7.3-fold, Latinos 5.5-fold, etc. So all in these very young age groups, we're seeing this is twice as high, right, as the age standardized measure of 3.6. And I'm sure well, if I haven't lost all of you in this sea of numbers, I'm sure you have noticed this one, which is the highest rate ratio that we saw among Blacks between the ages of 35 and 44, who had a rate ratio of 9. And the way you would describe this in plain language is that among adults between the ages of 35 and 44, Blacks are 9 times more likely than whites to die of COVID-19. So that is one way that we looked at the disparities. And I think the take-home message here is how important it is to look separately at age categories, because we lose a lot of information about these very high risks among young adults to middle-aged adults. It's high among all groups, and the bulk of lives occurring among elderly people. But these very high risk ratios in young adults is deeply worrying. And there's another way to capture this. And we also analyzed the data in this way. These are years of potential life lost between the ages, before the age of 65. Let me just say a little bit about that cut point of 65. I already told you that it's a measure that we use of premature death. It's a very exacting standard. I think everybody would agree that someone who dies before the age of 65 has died too young. Not that all of us don't want to live as long a healthy life as we can, but dying before the age of 65 is too young. 65 deaths before that age also reflects the likelihood that someone may be leaving independent children behind. And it also reflects a cut point that has social significance. At 65, you become eligible for Medicare or universal entitlement, which is not available to people under the age of 65. And many people think of 65, although it may vary a lot these days, as the age in which people retire. So here you can see that, that Blacks lost nearly 46,000 years to deaths as deaths before the age of 65, Latinos 48,000. And a way of saying this comparatively is that the number of years lost before the age of 65 was nearly 7 times higher for Blacks than for whites. 5.5 times higher for Latinos, 4 times higher for American Indian and Alaska Natives, and 2.6 times higher for Asian and Pacific Islanders. I don't think I've mentioned that the Navajo Nation and indigenous people in general are in the midst of a terrible pandemic. So to summarize what we've learned about the data in terms of dying from COVID. First is for everyone. The risk of dying from COVID goes up enormously with age. Compared to younger age groups, it goes up 300% by the time you reach older age groups. And for all of the groups that we examined, 80% of the deaths were occurring among people above the age of 65. Nonetheless, I think we have to be attentive to these very large disparities that we see among young adults into middle age, that even when we age standardize our mortality rates, we would not have seen these very high risks again between the ages of 35 and 44, a 9-fold higher risk for Black Americans. And of course, this has meaning in our everyday life in terms of people having to be aware that younger age has a disproportionate risk for people of color. We're still learning about the risks for younger people as this novel coronavirus moves into younger populations. And then, although these data don't tell us the why, they just tell us the what, we do have numbers of reasons that have been offered. The first one that's always offered is that there are higher rates of what are called comorbid conditions among people of color than among whites. And that's true. Obesity rates are higher, diabetes, chronic lung disease, heart disease, all conditions that can make you more likely to have a fatal outcome of a COVID infection are more common among people of color. But I should point out that these conditions are common among everyone. Something like 60% of American adults have at least one chronic disease, 40% have 2 or more. These are common conditions, and their relative risks are, these ratios I've been telling you about, are usually confer something between a 20% to twice as high risk, nothing like the 6-fold higher, 9-fold higher that I've been showing you in terms of racial ethnic disparities and risk ratios for COVID. Another reason that's often offered is that people aren't following public health advice. And there are a myriad of reasons offered for this, that they didn't understand it, that it wasn't conveyed, that they didn't trust the information, that it wasn't offered in a language or in a way that was familiar to them. What often is, and that's fair enough, but what I've often been interested to observe is very often the differences in exposure are not raised as risks. And these exposures being principally at work, but we shouldn't forget the fact that many communities of color are rent pressured and live in overcrowded housing, which may often be multi-generational. We forget that when we talk about essential workers, that it was a really fairly big chunk of the US workforce. We think of it as comprising of the health workers who have been extremely valiant and are continuing in as this virus has cut a swath through the southern part of the United States, continue to be extremely courageous. But many of the frontline essential workers are not working those jobs. They're working in supermarkets and warehouses and delivery vans, and are traveling to work on public transportation or other forms of crowded transportation, and are disproportionately people from color. The privilege of working from home, which I'm currently doing, is not one that is widely shared among communities of color, with a real minority of Black and Latino workers having work that allows them to work from home. And of course, I haven't mentioned the transit workers or the cleaning service workers, who also are disproportionately Black and Latino. I am up to my last slide. If someone was going to cue me that I was running down the clock here. I thought I would end with some words about what underlies these numbers that I've shown you. And what I would argue is that they are a reflection of the ongoing fissures that result from racism in our society. Racism that decides what kind of education you're likely to get, what kind of place in the workforce you're likely to have, what kind of housing you have, what the level of safety at your job. All of these are deeply moderated by racism. And that's why it's important that we all understand what racism has done to the contours of our society, and that we prepare ourselves to identify and acknowledge its presence in all of its forms, whether it's internalized, interpersonal, institutional, or as it usually is, structural or systemic. And that part of compassion is taking the responsibility to speak out against these racist narratives. A narrative that says that the problem is the people should always be interrogated as a racist narrative. I talked about the comorbid conditions often being trotted out. The problem is in the bodies of people of color, without having a conversation about what creates the risk for obesity, discussing the ways in which people have access to, meaning both the ability to buy, meaning that they can afford it, and the ability to find it, meaning that fruits and vegetables are available in your neighborhood. So what it means to have access to healthy food and thereby a healthy diet, and what that means about all these comorbid conditions. Additionally, all of the conversations saying that people don't understand flies in the face of what it means to have a job that's listed as essential, as having to go to work in order to make a living and pay your bills. For people in the Navajo Nation, where 30% of households have no running water, telling people to frequently wash their hands and then saying they just won't do it, really is the opposite of compassionate advice. It's cruel advice because people lack the capacity to do it. So that's what it means to look at these data and take it an additional step and acknowledge the enduring impact of racism in our society, and advocate for the policies that would make our current COVID-ridden world safer for all of us. That would mean people having access to sick leave so that they don't go to work when they're sick, exposing people on their way to work and at work. Having access to health care. Despite the Affordable Care Act, we still have millions of people in this country, and all of the undocumented, who lacked access to ongoing preventive care. To talking about having safety at the workplace, having personal protective equipment provided, having the ability to socially distance or keep 6 feet away from people, clearly is incredibly important. Making it safe for people who have to continue working so that those of us who stay at home can continue functioning really is a public health priority. So I think with that, I have another 15 minutes with you, which I hope that maybe we can have some discussion. I'm going to bring my picture up so I can see things again.
Thank you so much, Mary. That
was,
Hi.
And if there's not, I can talk more, but.
No, we have some questions for you.
Good.
So I'm going to just offer some of these up for you. That was really, really helpful. And I really appreciate that you began with definitions and, some of the data. Some of the questions from our audience, again, some of the questions have to do with causes of the greater mortality.
I'm happy to speculate.
Yeah, and of course, you gave many causes beyond comorbidities, but I don't know if you want to reiterate some of the things that you had said during your talk. In terms of why the rate ratio is so much higher amongst people of color compared with whites.
Sure. It's a combination. When I worked in city government, I learned pretty quickly not to say it's complicated, because that was sort of a killing remark. It means we don't know what to do, we can't do anything about it. But I'm going to say that this is more than one thing. So of course, if you have underlying health conditions, you are at greater risk of having a fatal case of COVID-19. But let's go back to how you get COVID-19. So in order to be at risk for a bad outcome, you have to get infected first. And I think that what's often been left out of our conversation about these racial, ethnic inequities in COVID outcomes is the workplace and the home environment. So that the exposure of people to COVID-19 who are working seems, we shouldn't have to argue about that. As people have gone back to work in every setting that I'm aware of, we've seen an increase in COVID-19 and novel coronavirus circulation. So additionally, of course, people come home to crowded households, and those households can be multi-generational. So you might have a young working person bringing COVID-19 home to an elderly family member. And all of us heard stories about how terrified workers have been, transit workers, sleeping in their cars because they didn't want to place their families at risk. So another thing that I didn't mention as a potential solution is offering alternative housing to people whose jobs mean that they have to keep working if they want to continue to make a living. And for people who are at very high risk, I think we should have a conversation about the fact that those people should not be working. And if they have somebody very, working outside of their home. So it is, public health always starts with exposure. because if you don't get exposed to this virus, you don't get infected. And then, of course, we want people to be able to seek care promptly and get care looked after, get tested. But the best place to stop this is with exposure.
Thanks, Mary. You know, I wanted to ask you too about, there was a study from New York, and because I know you were the health commissioner of New York
Yeah.
City, I wanted to particularly ask you about this. One of the studies also pointed out was really that there were disparities even within New York City that were at least in part the result of differential access to resources, medications, equipment, not just PPE, but actual resources to offer to patients between the different hospitals, public hospitals versus
Oh, you're
private.
talking about that, yeah. This was an article that said that there were very high mortality, much higher mortality rates at some hospitals than others, in particular the public hospital system. Yeah, I trained in the public hospital system.
Mm-hmm.
So I know that the doctors are really great and very dedicated, but they're looking after very sick patients who the private hospitals often don't want to look after. And they also work under hard conditions. The hospitals that had such overwhelming demands obviously makes it really hard to care for people. So I haven't been there. I know that there have been anecdotal accounts that that these hospitals ran out of everything. And I know that the head of the public hospital system of New York insists that didn't happen. So I really can't tell you.
Yeah.
But certainly the onslaught on the public hospital system was real.
Yeah. And one more example of institutional racism that you spoke of, or perhaps structural racism, because it's not the institution
Yes.
really that's at fault. It's the
Well, they've been
allocation of
underfunded.
resources.
Yeah,
Exactly.
they've been underfunded. Right. And I guess what I feel about this is what worries me about this conversation when people say the public hospitals were delivering like lethal care is that, well, some people interpret it that way, is that somehow privatization would fix that, when that seems extremely unlikely, because the private hospitals were there. They could have opened their doors.
Mm-hmm.
The reason they don't want to look after poor, sick patients is not because they're barred from doing so. It's because they don't choose to, and it would be very naive to think that that would change if we privatized the entire system. So New York City would have been in very bad shape without its public hospital system.
Yes, exactly. I only brought it up to emphasize the need to be more mindful of how resources are distributed and the funding available for, the hospitals and clinics and community health.
At every level, the salary scales, for every level, from physicians through to people who are, making sure that the place is clean. The public hospital system has suffered. It's
Greatly.
Always running in the red. And
yes, of course, and it's just
and
not.
The private hospitals are always in the black. I wonder why.
So we have clinicians, in the audience, and this does come up, and I actually just, I've heard this a lot amongst colleagues. Can you give us an example of naming and calling out racism when you hear it? How do you interrupt racist narratives so that the person you're addressing doesn't just walk away dismissively?
Yeah.
Really,
well, it's pretty uncomfortable. I mean, I talk about these things a lot, and when I first started, even using the word racism felt like people would respond to it by saying that's hostile. Now, I think we've come a long way, and we have people using the word racism in, in the halls of Congress. And so, but on a personal level, it is in fact often difficult. And I guess what I do is I tend to personalize it. it made me really uncomfortable when you called, this person by her first name, when, she's an older woman, and I think it would have been a good sign of respect to call her Mrs. Williams. Or, you don't know what this person does for a living. Why should you assume that they're unemployed?
Questioning assumptions and just naming exactly what you've heard. And
I'm not going to say it's easy. I think institutions should consider investing in doing some training. Certainly when I was a health commissioner in New York, we did a lot. We had, sort of two wings to our effort. One was an internal one, and the whole senior leadership team. And by the time I left the health department, a fifth of the workforce had a one-day training.
Had what? I'm sorry.
One-day training, a full day. And I don't know whether it's continued, but so that was, that's what it takes. You all remember when Starbucks shut down to do a training. So right. I think that's that it's never going to be enough to just rely on individual interactions. There needs to be an institutional investment in supporting these conversations.
And we can advocate for that within our own organizations. I think you're right. There's a question here too about whether you can speak to the potential health risks to people of color directly related to opening schools. Quite a concern also.
Yeah, this is a really complicated one because we know that the closure of schools has had a huge disparate impact, with Black children falling even further behind Black and Latino children. So it is important that schools resume their function. And also, who knows how parents are going to function if they're supposed to be going back to work and their kids don't have school to go to. So, but it has to be safe. And, all of these risks are racially patterned. And all I can do is encourage parents and teachers to stand up for safe reopening of schools.
It's so complicated, isn't it?
It is complicated. I mean, it was the thing that I wish we had more data. It feels like we should by now, about pediatric transmission, about the role that schools could play in transmission. We know that Sweden decided not to close its elementary schools. It feels like they ought to have some data that could help us, but I'm not aware of it. I do know that there have been very few outbreaks that have been traced to schools. One in Israel, I believe. But I do think that we are operating with very imperfect information, and it ought to be possible to have better information. I saw something pop up about boycotts, and I just can't go there. I really hope that ways can be found to safely reopen at least elementary schools.
It would be just fantastic.
If there's COVID, ripping through a community, obviously that makes it really much harder to reopen the schools.
Yeah. It would be helpful to have some guidelines about, what rate community spread is occurring, beyond
and
what you
sort of actual cut points. Exactly. I know that people have been putting these out, but I don't know anybody who's been willing to stand by a cut.
Yeah, or on what basis they might have evolved. Right. I just really want to ask too about, I know it's time to wrap up.
It is. My goodness.
Sign, but
wow, thank you.
One last word about data collection. To your very point about why we don't really have enough data at this point in time, can you say a little bit more about what would help us? What kind of data collection and reporting systems would be ideal in this situation, really to guide policy at all levels, I don't know if you can comment on that.
Well, I really feel that that the federal government should be more transparent in its availability of data. So the data that I showed you, we still can't analyze by gender. We don't have information on educational attainment, which appears on death certificates. That's so they, you know, all of these are data that exist that should be being made publicly available, so that we could do these multi, you know, by race, by gender, by age, and they should make it publicly available.
Yeah.
And then there are these natural experiments, which, if we want to call them that, which could be taken advantage of to see if we could get a handle on transmission dynamics. And it really should. The problem is, you know, I just, don't get me started on how fragmented and irrational the response has been. I think as people from one of the wealthiest countries in the world, we feel humiliated in public health about the way in which this response has
Yes.
unfolded. Well, with those cheerful words, I guess I better let you move on.
Well, I do want to thank you so much,
My
Dr.
pleasure.
Bassett. Thank you for being with us today. Thank you for speaking with our audience. To our audience, I want to remind everybody to keep an eye out for the recap of today's session, and there will be another email that you will get that will contain a link, so you can get continuing education credit after you do a brief post-test. There is no Friday session, conference session this week. We look forward to having you all come back on Tuesday, August 4th. This will be a very exciting panel of overcoming stigma towards people with substance use disorders. This is going to be a panel moderated by Dr. Sarah Wakeman, who's the medical director of the Mass General Hospital Substance Use Disorder Initiative. And the panelists include Ayanna Jordan, Associate Director of Psychiatry Residency Program and Assistant Professor of Psychiatry at Yale, Dr. Miriam Kamaromi, Medical Director of the Graken Center for Addiction here at Boston Medical Center, and Windia Rodriguez, who's a recovery coach and a team lead population health management for Partners Healthcare. So from all of us to all of you, thank you for attending, and we look forward to seeing you again at our next session. Thank you so much.